channel. In this video I will discuss what is Addison disease. So Addison disease is a condition when adrenals are unable to produce or release cortisol and aldosterone. So these two hormones are mainly not produced by the adrenal cortex in Addison disease, and it is actually the primary adrenal insufficiency. That is, problem is in the adrenals, not in the pituitary. There are several causes for the development of Addison disease in our country and third world countries. The cause is tuberculosis. Other causes include metastasis from different cancers, for example lung cancer and breast cancer. These can metastasize to the adrenals and lead to Addison disease. Other causes include bilateral adrenalectomy if you have removed the glands, and also if there is meningococcal septicemia, you have Waterhouse-Friderichsen syndrome, in which there is necrosis of the adrenal glands. Waterhouse-Friderichsen syndrome. There are certain other disorders like autoimmune, and you should remember that autoimmune diseases are the major cause of, or the most common cause of, Addison disease. We have a condition known as adrenoleukodystrophy, in which this Addison disease develops in the younger patients. In this, there are long chain fatty acids that are not metabolized by the peroxisome, and therefore these get deposited in the adrenals and therefore can lead to the development of Addison disease in the young patients. Then we have congenital adrenal hyperplasia. Also, HIV infection, cytomegalovirus infection, and some other infections can also lead to the development of Addison disease. What are the signs and symptoms of Addison disease? Actually, the signs and symptoms are very non-specific, and ultimately the patients go to a psychiatrist for their signs and symptoms. The signs and symptoms are fatigue, weakness, anorexia, weight loss, orthostatic hypotension, that is when the person gets up from supine position, then he feels dizziness, salt craving because patient is losing salt due to hypoaldosteronism. Then there is hyperpigmentation because there is increase in the production of ACTH, and along with the ACTH you will also get increase in the melanin, and when there is increase in the melanin, then you will get hyperpigmentation, especially over the knuckles of your fingers, elbows and palmar creases, back of the neck, etc. You also get nausea, vomiting, abdominal pain, diarrhea, arthralgias and myalgias. You should remember that due to this diarrhea, your hyperkalemia can be corrected, and you cannot can't get sometimes hyperkalemia in the labs. Labs are neutropenia, labs show lymphopenia, lymphocytosis, eosinophilia, that is rise in the eosinophils, and there is decrease in the sodium levels and increase in the potassium levels, and sometimes you can get hypoglycemia because cortisol is a stress hormone. When it is released, it causes increase in the blood glucose levels, while when you have Addison disease, then your RBS levels are low because of lack of cortisol. You should do tests for plasma cortisol levels at 8 am in the morning, and if these are below certain levels, that is less than 3 mcg per deciliter, and there is increase in the ACTH, then this is suggestive of Addison disease. Then you should do co-syntropin stimulation test. Co-syntropin stimulation test is done. We give 0.25 milligram of co-syntropin intramuscularly, and actually this is ACTH, and after 45 minutes we get the cortisol levels. If it is less than if it is more than 20 mcg per deciliters, then Addison disease is primary adrenal insufficiency, that is it is ruled out. While in Addison disease you get less than 20 mcg per deciliter of serum cortisol levels after giving co-syntropin. Furthermore, imaging should also be done. Imaging includes CT abdomen, pelvis, and it shows any infiltration, malignancy, metastasis, or calcification. Calcification is seen in tuberculosis. Calcification is seen in the tuberculosis, and in autoimmune disease you will get small adrenals. DDs include secondary adrenal insufficiency. In secondary adrenal insufficiency you will not get postural hypotension as well as hyperkalemia, because the aldosterone release is not dependent on the ACTH from the pituitary, and in secondary adrenal insufficiency you will get low ACTH levels. Treatment of this disease is very important, because when the patient presents to you, in most of the cases the patient presents to you in adrenal crisis. Adrenal crisis is a condition when the symptoms I have told you above are all exaggerated, as well as you can get extreme abdominal pain like acute abdominal emergency, and you can get fever from the underlying infections or any underlying cause. You can get the features of that underlying cause. So in this case you can also get coma and refractory hypotension, that is not responding to vasopressors and fluids. So in this scenario you will give IV fluids, you will give antibiotics, because most likely the precipitating agent will be any bacteria or infection. Then injection hydrocortisone, it is given as 100 milligram bolus, and then 50 milligram QID every 6 hourly. These patients mostly also have vomiting, and for vomiting you should also give antiemetics, especially ondansetron 8 milligram SOS IV 8 milligram SOS or TDS. And if you are sending these patients home, but before these all treatments you should also do some labs. These include CBC, RFTs, serum electrolytes to check hyperkalemia and hyponatremia. Also you should do serum cortisol levels, serum ACTH levels, and blood cultures. Blood cultures should be done, because in most of the cases of adrenal crisis the infective organisms are the underlying cause. Then when we are sending the patient home, then we should send him or her on the maintenance doses. These are maintenance treatment is tablet hydrocortisone 15 to 20 milligram in the morning. Let's say we will start at low dose, that is 15 milligram in the morning and 10 milligram in the evening. We should also give tablet fludrocortisone acetate. This tablet is actually acting as the aldosterone hormone. So fludrocortisone acetate is a mineralocorticoid and it should be given in a dose of 0.05 milligram to 0.3 milligram OD, that is once daily, or you can also give it on every alternative day. This tablet fluorocortisone acetate should be added when there is postural hypotension and hyperkalemia and hyponatremia. But if it is intolerable by the patient, that is patient is getting edema or hypokalemia or hypertension, then you should stop this medication. So in some females you can also add DHEA, that is a male sex hormone, 50 milligram once daily, and it improved their mood as well as their bone mineralization and reduced the fracture risks. So this is all about Addison disease. Thank you for watching.